Greetings and welcome to the International Pediatric Simulation Society podcast. This show is for people passionate about pediatric simulation-based education, training, and research. Podcast hosts are members of IPSS, a global community of multidisciplinary healthcare professionals from over 30 countries, all dedicated to improving the care of infants and children worldwide. Each week, one of our sub-hosts, Christine Bailey, Elaine Ng, Aaron Karn-Bennett, and myself, Samreen Vora, will introduce you to a new guest and bring you into a conversation with simulationists and healthcare professionals from across the world. Come along.
We're very excited to have our guest on the IPSS podcast. I'm Elaine Ng, one of the co-hosts on the IPSS podcast team. Today we have Sarah Patterson joining us. Sarah is a friend and colleague. She is a child life specialist. She is an associate professor of pediatrics for over 20 years at McMaster University, with contributions that include interdisciplinary teaching, faculty development, and promoting excellence in child healthcare education. She's the immediate past president of the board of directors at the Association of Child Life Professionals. So we're very excited to have Sarah here. Welcome.
Thanks, Elaine. So happy to be here.
So Sarah, since we have an international audience, maybe firstly clarify where you work. McMaster University. I know exactly where it is.
Yes, of course.
But maybe many people don't.
Yeah, McMaster is about an hour from Toronto. So it's in Hamilton, Ontario, Canada. And it's quite a large university. I'm housed in pediatrics and health sciences. And I think what really has put McMaster on the map in medicine is problem-based learning and case-based learning. And so we're being in a psychosocial profession, we're really fortunate to be housed in pediatrics. So we work a lot with medicine and the pediatricians, and we co-teach together quite a bit. So it's great.
And you've been a child life specialist your entire career.
That's right. So 33 years ago, I started as a child life specialist. I'm going to tell you just a little bit about child life because a lot of people, we teach our child life students that elevator pitch because a lot of people do not know what child life specialist actually does. So as a certified child life specialist, you're really a trained professional who supports children and families who are navigating stress of illness, injury, trauma, in hospitalization. So child life specialists are experts in child development, family systems, therapeutic play, trauma-informed play. And so we really help children and their families, their siblings, their grandparents, understand and process what's happening during hospitalization, to reduce trauma, to foster trust, to increase development in children, and somewhat normalize such an abnormal environment. So really grounded in child development and minimizing psychological harm. There's a lot of child life specialists now in community and education settings. You'll find them in hospices now, in clinics, some dental offices, and you'll find this around the world. So internationally, so the association I was president for, we have about 7,000 certified child life specialists all over the world. So we're talking, the Middle East, in Asia, all over. In a few countries, it's known as hospital play specialists, but to become a certified child life specialist, there's an internship component and quite a bit of education requirements. So that's it in a nutshell. But the big part about child life is we aim to meet the child at their developmental level, not at their chronologically age level. And we help them through procedure and tests, really being that translator of what hospital, some kids, they'll say, oh, I'm going on a stretcher. Are they going to stretch me? Those little things go a long way. So in short, we kind of bridge the gap between the clinical world for the child to their own world.
It's very funny, the comment about the stretcher, how they think they will be stretched.
Yes. And just like CAT scan, will there be cats? Or, sometimes we say, and this, we're going to put you to sleep. And then I've had, children say to me, my dog went to sleep. Those little things that we're so used to.
Right. So how did you get into simulation?
Oh my gosh. So I had been a child life specialist for, oh my goodness, almost 20 years when I ran into simulation. So about 11, 12 years ago, I started writing a master's degree with two colleagues. And in that, attended a workshop on simulation at the Center for Simulation Based Learning at McMaster University. And just blew me away. I just knew this was something that just resonated, but that just didn't happen in child life. I had not at that point found a child life specialist who was involved in simulation. And I just thought, what an amazing way to mirror what we're doing. And it also made me think ethically is that I had so many child life interns who came and I allowed them to practice on patients these really difficult conversations and these everyday conversations. And of course we were making errors. And I thought, why aren't we doing this? Why aren't we practicing? We spend a lot of time with kids at end of life or the most traumatic, most vulnerable moments, but we were teaching theory, but not letting them practice before they went into placement. So this was a game changer for me. And then when we wrote our master's degree, which is now going into its 10th year, we developed a child life preparation course, a 2-year master's degree. And then we built a 2 year master's degree for interprofessionals in pediatric psychosocial care, where we do a lot of simulation with standardized patients. So often looking at the emotional safety, clinical technical skills are so important, but we often don't have the time to focus on the emotional side. And so teaching both child life and interprofessional care professionals how to have conversations with people, which we don't always have the time to learn when we're going through our professions. So this was really a game changer for me. And then when I started meeting simulation professionals, reaching out to them, simulation professionals are a whole different being. Like there's something about the inclusiveness and the willing to teach you and the willing to meet you where you're at and accept psychosocial care. Like for instance, I'm the first child life specialist that was on the board for IPSS. And it was a no-brainer. People were reaching out to me. Would you like to, contribute this? And it just felt right. The simulation world just felt such a part of child life that hadn't been tapped into.
So would you say simulation now is a core part of the curriculum in the child life specialty?
Yes, absolutely. And we actually teach a milestone course in our program all about just what simulation is and how is we get child life specialists and learners from all over the world and how to bring it back to your organization and how to embed it. Whether, we do a lot of simulation with children already with like listening to MRIs and practicing procedures before they go into it, but we didn't always do it with our learners. And so that's the big change. And I really think it makes such a change on the quality of healthcare.
Can you clarify how you get your standardized patients since your patient population is pediatrics?
Yeah, so that has been a challenge. I will tell you, we often use our standardized patients to reflect teenagers or parents. And that's what we've done so far. There has been times where we've brought in some of our own children for role plays, but the actual standardized patients and we do more conversations with parents because we know when parents are stressed, it trickles down to the child. So working with the parents, but we also have a lot of great standardized patients that actually role play really well, like a 15-year-old, a 16-year-old. So that's where we've done most of our simulations. And there was a stat that came out of the U.S. recently that 80% of children and families that have some type of hospitalization can be negatively affected with trauma that often can interrupt daily life effects. And so by using this and simulating more and more, I think we can decrease the trauma and harm, but we often don't think about that emotional safety side versus clinical safety.
So when I do my simulations, I would pretend to be the parent for the scenario. So do you get someone to pretend to be a 4-year-old? How to get around that?
Yeah. So what we've done is we have never had someone do that. We've used AI a little bit. Really have to ensure that the developmental piece is there, but it's really difficult to do children. So we've either had AI do that, talk through a mannequin, a child mannequin, or just stick with the teenager. So it's still a tricky side with pediatrics, absolutely. But we work around it. We do have our students sometimes sit and say, it's not the fidelity isn't high, but here's a case. How would you explain it to a 4-year-old? But most often with simulated patients, we have to use mannequins or stick to teenagers. That's the tough part.
Yeah,
Or
but AI has really been a game changer as well. We saw that demo a while back when you can ask ChatGPT to practice and role play with us.
And I think that's important because we've tried to tell our students, before you go into a situation with your preceptor and your internship, because they do almost 8 months of internship. And so have that, pull aside, take your phone and practice it with an AI generated simulation. And I think it does make a difference because we often don't get the chance to practice with a 4-year-old, with a 5-year-old when we go in. And the mistakes we made emotionally can have huge repercussions. I read a study once that from special needs parents, that 92% of parents had some kind of trauma from receiving the diagnosis, which is fair. But we get one shot to do these really difficult things sometimes. And I feel like, you think about my child had some healthcare issues, or I think about my parents, and I really remember what people said to me. And sometimes you say what you think is the right thing. So we have these checklists. For instance, I think I mentioned to you, my father died recently. And often when I'm in healthcare situations, I don't say I'm a healthcare practitioner because that's always kind of observing how the other side lives. And when my dad died very suddenly, and when my dad was dying, she said, come to the bedside. This is a beautiful moment. He's taking his last breath. And I thought, this is what she's been taught in palliative care. But it wasn't a beautiful moment because it was very sudden. He didn't have cancer. He hadn't been sick. He was out for dinner, the couple nights before. And so it just made me think about that emotional safety pieces. We're taught these checklists of what to say, but we never get to practice it and realize how, if she had the opportunity to say to me, and I did give that feedback to the hospital, but how did that make me feel? It made me feel like his death was discounted, and it wasn't a beautiful moment. So those type of things, we talk about halo, but at the same time, everyday conversations, parents remember. I've had so many conversations when parents leave the hospital where they do remember what was said to them, even in the everyday conversation. So we're always so busy, but I think simulation is a beautiful chance to practice these things.
And then you couple that with a debrief and a discussion and then reflection. And that's the power of simulation, isn't it?
Well, that's it. Because, when you debrief through a psychosocial lens, you go beyond what happened. We say, what could you have said? Was that developmentally appropriate for a teenager? And so they're not about the performance, but finding that blind spot about how did that feel for the parent or the family, and what did your body language send? What message did that send? And I think in the past we used families as distractors sometimes. And so I think we need to incorporate caregivers and parents, not as background characters or distractors, but part of the care team. Because sometimes I've seen simulations where we view them as obstacles or complications in high-stakes simulations, but in real clinical environments, patients should be, patients and families, essential partners, and their fears and advocacy is not a distraction, but it's real life. And so did we build trust with that family, or did we create unintentionally more fear and harm?
I would have thought you would have to build a lot of simulation scenarios for child-life specialty, because it's not like one of the more mainstreams, like resuscitation, procedural skills. This is conversations in your specialty. So how was that process?
So, it's funny that you asked me this because when we started our program, financially, I was like, how am I going to afford to train these standardized patients for my cases? So what I did, McMaster has an incredible amount of 400 cases, and I went through them, all of them, And I found ones that I could use without focusing too much on the medical. So sometimes it'd be a new diabetes diagnosis, or, the parent is angry because the doctor prescribed the birth control pill for a child, and that brings up a whole cultural humility experience, and engaging with the parents. And so I just went through all these cases and found ones that I thought were important and I could use. And I have created cases in the meantime for simulation, but I still use a lot of those because the the standardized patient has done it over 100 times and they know it so well. And I always find when we do this, I bring the simulated patient into the debrief and say, how did that feel for you? So the students can see. And the experience is always really rich because they've done this so many times with so many different professions that we really get some great background on what the differences were with these people trained in pediatric psychosocial care. And we have doctors and nurses, and we have a therapeutic clown in our program and a pediatric dentist. So we've been teaching lots of different professions in addition to child life in these simulations. And it's always so interesting to see their blind spots, the gaps, and then how it all comes together. So that's a great question because I don't know if anyone's ever asked me that, but we really need to define like that trauma-informed care, that family-centered practice, the strategies, even, for different capacities of sensory and emotional needs for children and families. And that was one way that, you could use it in your own cases. You just got to find the cases. And sometimes if you have the time, throw away the medical checklist,
Right.
which is hard for people.
Yes. I want to pick up on something you've mentioned a number of times now. You use the terminology emotional safety, whereas the term psychological safety is the one that's referred to quite frequently. Can you tell us a little bit more about that?
Oh, I would love to. I'm so proud of this initiative that the Association of Child Life Professionals has taken on, and I'm also researching it in my doctoral dissertation. But emotional safety is really the experience of feeling secure, respected, and supported emotionally, especially in vulnerable situations. So, like being in the hospital, procedures, receiving a new diagnosis. In healthcare, we often prioritize physical safety, and rightly so, but emotional harm can be just as long lasting and sometimes more difficult. Sometimes we can fix broken bones, but we can't always fix the emotional harm so simply. So I think it's really important that children and families receive effective clinical care, of course, but they also need to be seen and heard. And, predictability is a really difficult thing in the hospital, that ensuring respectful interactions and giving families and children control where we can. So the concept is so essential because it doesn't separate emotional from physical experiences. So a painful procedure can be confusing or frightening, and then it shapes how children engage. So if we can make these interactions less frightening and more emotionally safe, so it protects children and families from trauma, from fear, lack of preparation, feeling powerless, misunderstood. So that's why I think it's such a central concept in pediatrics and simulation. If we don't address the emotional needs of children and families, we risk doing harm when everything medically goes well. That's the really hard part, is sometimes medically everything goes really well, but emotionally we've caused harm. So the Association of Child Life Professionals launched an emotional safety initiative, I think in 2021. And I'm so proud of it because it really reframes emotional safety as a critically component of high quality care, somewhat of a movement that addresses the emotional harm in healthcare environments. So it was really a call to action, not to child life specialists, but the healthcare community. There's an actual emotional safety initiative.org. There's a separate website with tons of resources for healthcare professionals, and just to raise awareness about emotional harm and strategies to reduce trauma and support resilience in patients and families. So at its core, this initiative is really about leveling the importance of physical with emotional safety. So there's resources, assessment tools, there's a white paper, executive summary. We brought a lot of people to the table to build this initiative, like American Academy of Pediatrics, the Joint Commission, a lot of U.S., the Institute of Safety and Healthcare Improvement. So it's really been meaningful, and it's really being spread around the world now. But it just capitalized that emotional harm is real harm. And in our systems, we need to prepare healthcare providers to recognize and address it with the same commitment, safety as physical safety. So shifting that mindset, and, we wouldn't tolerate physical harm to a child in healthcare, but sometimes we have to recognize more and address emotional harm with the same urgency. And so this is what's so fascinating, is that there's actual hospitals in the US now that are creating metrics for emotional harm alongside physical harm. So for instance, if you ordered the wrong med for a patient and family and it came, and that would be followed up, but it would also be an emotional harm risk because the lack of trust with that family now, and the risk and the emotional harm. So this, long story longer, I'm really passionate about it, is I just think that it starts with education, and it starts with simulation. And I really think eventually it will be embedded, just like the 6 vital sign or hand washing or informed consent, that people eventually will buy into emotional safety, and it'll become a standard of care. And it starts with education. And that's why simulation is the powerful platform to incorporate emotional safety.
How have you been doing Sims to promote this?
Yeah. So thank you for asking me this, because I really do love this. I've used teenage actors and parents real time for developmental appropriate feedback, and asking the standardized patients whether they feel heard, rejected, scared. And that can be within a clinical, it can be, in the emergency room, and you can pull that standardized patient and say, how did you feel? You can design, more emotionally complex scenarios, or use your scenarios and integrate a little bit more about a parent who's overwhelmed during their child's deterioration, maybe a teen pushing back on a procedure. All of those things have, I think, emotional safety layers of pediatric care. And then in the debriefs, like I said, think about those feelings, incorporate caregivers not as distractors, bring in more interprofessionals, involve child life or psychosocial experts in the scenario design, in the scenario makes a difference, and use simulation as advocacy for patients and families rather than a service. Is like, how do we speak up when we think emotional safety is at risk in real world practice? How do people actually see what's happening and be able to respond to that during a clinical scenario? And greater focus on metrics, I think. Like, how do we assess emotional safety competencies? Not through checklists, but through most often reflective practice and behavioral indicators. So how do we continue to build those metrics? But I think simulation offers this opportunity because the debriefing, the reflection, to be able to practice it and bring these abstract concepts to life, which will create behavioral change. It's really shifting. It's like a catalyst for cultural change in the hospital. And really, what we say matters, but we're never able to practice that. And so ultimately, simulation should be all dynamics of pediatric care, which includes medical teams, but also adolescents, children, and their families. And then shifting those values on physical safety to include emotional safety. So I think it happens every day in healthcare. Emotional harm is real harm. So let's, through simulation and bringing more psychosocial care, and even if you don't have child life or psychosocial care, emotional safety is everyone's business. Let's just reduce that harm and place it with trust while we're doing those clinical scenarios. It's not easy. And emotional harm happens every day, unintentionally, invisibly, but we know it happens because we hear that feedback from patients and families. So it will also drive better indicators for quality in care and parents' reports. When I've had interviews with parents after different situations, sometimes they don't remember medically what happened, but they remember emotionally what And that's what we need to remember, is that we may be fixing them medically, but we may be doing also harm at the same time, which is not why we're in healthcare. And no one goes into pediatrics for that reason. So I
Right.
think it's the changing culture.
Yeah, we all mean to do our best,
Yeah.
but sometimes it's not quite as intended.
And you know what I think is incredible is this emotional safety idea is international now. So in Saudi Arabia right now, they're writing emotional safety curriculum to be taught across all healthcare professions and in simulation. And, there's a lot of international collaborations that are bringing like culturally relevant psychosocial practice into the simulation design, which is new. And I just think it's so exciting because simulation it's somewhat like a mirror. It shows us not only what we do, but how we make people feel, right? In the situation. And so it's not technical in any way what I'm talking about, but it's a humanizing way. And I think in so many simulations we do, we can incorporate small tweaks that make a big change in culture.
Have an idea here, and I'm not sure if this is going to work. So I'll see what you think. In acute care resuscitation
Well,
emergencies, we tend to do a lot of simulations with mannequins. What you've been saying, that, it takes a standardized patient so you can actually role play that situation in order to teach emotional safety. Can we marry the two together? I'm thinking not. I think probably our learning objectives needs to be one thing and separate it from something different. But is there a place to marry the two?
I think so. I think sometimes simulations are just technical because that's what's going to save the child's life, right? But if you have a parent by the bedside at that point, or if, if you have a patient who isn't sedated and is asking questions and those type of things you could debrief on, but it is difficult when it's, the patient is sedated and there isn't family around. But often there is even the emotional safety of how we talk to each other. So I truly believe emotional safety will also help us with burnout. So we talk about the psychological safety of, in simulation of not being judged, but there's also that emotional safety piece. There's a lot of shame. There's a lot of competition. There's a lot of stress in healthcare anyway. And I think sometimes that emotional safety piece about knowing how to speak to parents and caregivers will reduce burnout for people because they'll feel like they're giving better care. That was the beauty of child life. People would always say to me, "Oh, you get to be the good guy, right? You get to go in and make them smile," which was such a privilege. But at the same time, it is more difficult for other people because they often burn out having to tell these parents these difficult conversations. So in these simulations, if you don't have a child or a parent involved, how do we talk to each other? And I know closed loop communication, I know all those things, crisis resource management and simulation. I've taught all those things. There's also that emotional safety piece of how we're talking to each other and those slight tweaks that can garner more trust in each other in a really intense situation, which will also decrease burnout, which will allow you at the end of the day to go back to the parent and have that difficult conversation. So I do think there's many ways you can write this into, because that's often what people say to me. I've done this a few times. I did this as a keynote last year in Pakistan. And the first thing people said to me is how it's a great concept, but how do I do it? And I really think these little tweaks of putting some of these objectives in, very small objectives about trust and communication within that SBAR, that closed loop, is not only what we're saying, it's how we're approaching each other. And I think that makes a difference because we're in a culture too in medicine where burnout is at an all-time high, post-COVID, and we're too busy. We don't ever have enough staff. We're too busy. Internationally, everywhere you go, there's so many patients. People are living longer. Kids are living longer with certain diagnoses. And so it's so important at this time to merge that with physical safety. Because you're looking at physical safety and clinical safety through that whole simulation. Where can you put a little bit of trust and resiliency for each other in there? Does that make sense?
Totally. That's incredible. Thank you so much for sharing your insight into all this. Really enjoyed chatting with you about child life and simulation and what you've been up to. You're a very busy person. Perhaps we'll get you back in a future session when you've got more to share once you've finished your dissertation.
Yeah. Well, thanks for being interested, and really thanks for listening today, because I didn't realize how much language and environment and all these things matter in simulation, but they do. And like we always say, would you get on a plane if someone hadn't ever practiced it? So why am I allowing, people to have the most difficult conversations about practicing? So thank you for being interested and having me, because, child life is an unknown profession, and pediatric psychosocial care is often, I hate the idea of soft skills, but is also always seen secondary. But I think we can merge the two to have the same elevation and importance. So I really appreciate the time.
Absolutely. Thank you so much.
Thank you for listening to this episode of the IPSS podcast. A special thanks to our behind-the-scenes producer, the talented Danish Kumar, and to the Starship Foundation for providing the equipment that makes this podcast possible. Join us next time.